we're going to have to do a lot of that. So today is going to be brushing over a lot of different things. I'll make mention of things like syringes, INTs, three-way stopcock valves, or all these different things. But really on next Tuesdays, we're going to get much more into the nitty-gritty of what exactly these are and how an introduction into IVs and all that stuff. A reminder that Tuesday is going to be practicing on mannequins, and then next Thursday is going to be practicing on each other. I always push for, like, you have to do 8 live sticks. Dinner will usually bring it down to about 3, so we'll see where the fight goes. But well, it was none when I started, and I was like, no, that's not none.
You don't.
That you well, let me rephrase. Peer sticks. You have to do them for clinicals in the field and stuff. But I'm like, you're gonna be a surgeon. You should have to get cut on first to know how it feels. And so, in my opinion, you're gonna go out. I'm gonna send you out into the world. I did the same thing. Like Denner said in his medic class, he was like, I think Mr. Fearon was stuck by EMTs more in his first week than I was in my entire 6 years being here. Because it doesn't super bother me. And so every time I was on the truck, I would just say, hey, why don't you, before we start, you do an IV on me, before I let you do IVs on other people, Anyway.
It breaks the ice too a little bit.
It does, and it's a strong, especially now as we're moving into AEMT, we are far more discussing some leadership things. It's a little strange in EMT and AEMT where we teach you strong leadership skills and then you go out into the world to be a medic's assistant, right? But that's because this is the region we are in. It is not, we are in a very unique region where if you go outside of Georgia, the EMTs, AEMTs have substantial more authority. In fact, if you go to Grady, for example, the EMTs have more authority because they work a lot of EMT, or EMT, AEMT trucks. So anyway, the point is that it does a lot for leadership when you say, I'm the first one over the hill, I'm the last one on the helicopter. Meaning, if I'm gonna tell you all to stick each other, it's the same reason I do the NPA thing in EMTs. Is for them to be like, okay, I would never get that done. This guy lets people do it to him. That guy's a real one, right? It's you can do so much by showing people in that regard. So, anyways, this is just a reminder. You're gonna get big stuck anywhere from 3 to asterisks. So, and it'll just be checkoffs. It'll be a very kind of liberal lab where everybody's just milling about, calling an adjunct over to supervise them while they stick each other and all that stuff. So, we will be doing 20 gauge needles in practice. The truth of it is that the smaller a needle is, the easier it is to be successful because it's all about diameter, right? However, I want your standard to be 18. We'll get into this, I'm getting way ahead of myself, but the standard should be 18 because you can do almost anything that you need to do through a 20 gauge needle. In fact, the hospital, outside of giving blood products, which is larger, can do almost everything they need to do through a 20. So if you make your standard an 18, and you get used to that, you'll get better faster, first of all. And then secondly, when you're like, this is a rough one, I better downgrade it, you'll go to a 20 instead of a 22, in which case you can do very little through a 22. I shouldn't say very little, you can do less. Okay. We'll get into all that. Before we do that, this is day 1, AEMT class. Where's your lens at, Tina? Does it end like right here? That's what it looks like.
Yeah.
Okay. Make sure I hit the right angle on it, but we're now in AEMT class. It is notoriously more difficult, the registry is notoriously more difficult. Our success rate as an institution for EMT is something about around 80% retention, meaning 100% of people start, about only 80% of those people pass. And our first time pass rate for the NREMT for EMT is around 98 or 95%. What that largely means is that if you pass the EMT class, you are all but guaranteed to first time pass the EMT registry, okay? The national success rate for first time pass for AEMT is around 54%. That's nationally. Ours is not 98, it's about 70 something, I forgot, 70 something. So we can't say if you pass this, you are all but guaranteed to pass AEMT. The success rate drops substantially. Last year specifically, I think I had 11 students graduate and only one of them failed first time, and they are as of yet still unsuccessful in passing the AEMT and have to do a recertification. I would say that they noticeably struggled in class, noticeably struggled. and in fact, no one was surprised to hear that they were unsuccessful, right? All I mean to say is that we are way above the average in this institution for success for AEMT. What that means is that if you work hard here, you pay attention, and you are honest with yourself, you will do just fine, right? The world is struggling with the AEMT test. We are not, but it is substantially harder because, like, people like to call after their EMT registry, say, hey, Mr. Fearon, I want to talk about all the, and my default answer is like, I can't talk about that stuff. It can torpedo our program. I can't know what's on the registry. But truth be told, I don't need to know at all really what's on an EMT. I know it's there. My guys are passing almost 98 out of 100 times. Evidently, we figured it out. They don't tell us what's on the AEMT, right? What you'll notice is a lot of changes in the class, whereas if we do accept outside people, though it's rare, meaning somebody that didn't go through our EMT, and that's largely just because we do so much teaching in the EMT, so we do not have to do it in AEMT, so we can focus on what the test is going to be on. Because here's our assumption. Don't know this. Here's our assumption. Actually, do you know? What if I said, you just took the EMT registry, or most of you have, how do you suppose the AEMT difference is different? Why is it harder? Why are people less successful? What's happening there? Meds? More meds?
Med math, probably.
Med math? Okay. Would you be surprised to know that, in superficially, my students, they successful in the AEMT class, the general consensus is not a single person had a Mad Math question.
Well, that's good.
I don't know if that's true. Obviously, I don't know, whether they forgot.
But I like those odds.
It's now we still teach you here. We teach you a lot of things that the registry won't because it's what an AMT should know. And by understanding med math, you then understand these things that it will ask you, right? So, Tony, what do you think?
I think responsibility has increased. So.
Responsibility has increased. That is true. It's interesting. There's not a whole lot of discussion, it seems, on leadership-based testing. Doesn't seem to be a ton of that, but.
Is it because it's taking, for the same reason that they told us to try to take the national registry as soon as possible, because over time you might forget. So here we are taking, the assumption is we've remembered everything from last semester and we're layering on
That's right.
to it.
Sure.
So for the AEMT national registry, we have to take all this stuff that's been layered on, plus remember all that.
That's correct. That is,
That's a
I
lot
think,
more
part of it.
information.
Ultimately, I don't know, and it is very frustrating for me as an instructor. I'm like, if you just tell me what you want them to know, then I'll make sure they know it. But you won't, so we just have to try, right? Now we're doing well. We're doing 50% better average than the rest of the world, essentially, so we're doing very well. But how we do that is by essentially, what do you got, Trina?
Well, I was talking to, I actually have AEMT from Metropolitan Network today.
Cool.
And we were talking about it, and he was like, the AEMT, like their airway management questions are a lot more weird. Is how you explain it? I was like,
I think that's fair. That's the conclusion I'm coming to. I don't know if anybody's looked in depth at the schedule, but you might find that, I think what happens, I'll give you my speech as to why I think it's largely unsuccessful. First and foremost is, like I always say, I think people think that it's EMT plus, but really that should be viewed as paramedic minus, that we're not advanced EMTs, we're paraminis, right? Like, because you will see, especially me, because I was an aggressive medic, I'm an aggressive instructor, you'll see yourself at odds with some of the adjuncts who are like, yeah, I don't think you're supposed to do that. And be like, Mr. Fearon said I could, right? Because I'm teaching a ton of things where other medics are like, what the heck? Even instructors are like, why do you teach them that? And I'm like, it's in their scope. I read it in the small print, like, hello? Also, I would rather the transition into paramedicine be easier. I would rather, there's any number of things that can happen there. But you'll notice in the schedule, getting back to the point, is that we do not have a lot of trauma in AEMT, right? I think a lot of people kind of view the EMT class and then we expand all of those concepts. I'm like, okay, nope, let's expand these two primarily. What I'm starting to kind of get the conclusion is that the AEMT is largely pharmacological and medical focused. It is very much, do you know the physiology and pathophysiology, and then do you know the appropriate intervention for that? It's not just, an EMT we're just kind of like, I don't know, he's like not breathing, so I'm gonna help him with that. And it's like, great, Tell me what the lungs are doing. Tell me why the blood affects that. Tell me why a person could be breathing but still dying, and you're just like, ah. And so you'll find, even as I reuse some of the slides, it'll be mentions to like, hey, remember how we just were like, anyway, here's what this is next. Now you need to know this. You need to know this, not just reference it. You need to know this, right? And like Tina said, so much of what we're doing builds on the foundation. In fact, much like Trinity was saying, I think earlier, one of my, if you remember Miss Fox, who did very well in the class as well as in the field, she said, I said, you have one thing to tell new AEMTs. EMTs moving into A. What do you tell them? And she was like, well, I guess I would just say that there is a huge part of EMT understanding that cannot require thought anymore in A. Like, it should not be, okay, so who do I give aspirin to? It's like, you're doomed. What do you mean who? That's done, it's over. That's not something that should require your brain anymore. This should be like, boom, this guy's got chest pain, so I'm gonna run through my med check, back, forth, great. I did that because that's what you're supposed to do, but not that it took any of your brain power, right? You go in to give someone aspirin, wait, something in me triggered. Oh, that's right, I need to ask contraindications. Like, that should be obvious now. The reason I say that stuff is that if you encounter something that we kind of brush by or blow by, or I say, hey, this is like largely review, and it's not review for you, that is your time to dig into that stuff. You know, you hanging out? Watch me good.
Oh, I'm on.
Okay. Take notes. My stature, tonality. We're being recorded as well, so great. Keep that in mind. It changes the. No, that's Raylan's, but you know.
You can just throw it wherever. Out the window.
With Raylan.
It's my parachute, so
What I think happens a lot, and what really separates clinicians very commonly, is how they approach things they don't know. Also, you being here means I'm going to bounce things off of you, so we'll see. If you give me an example of, or I'm going to give you an example, and you tell me maybe how you might approach that. You show up on scene, and the patient needs a medication, and fire says, hey, why don't you give rocephodron? And you're like, well, I don't know that. It's never been in my scope. Later that night, you pull up your protocol, and rocephodron is in your scope. What do you do from there? How do you approach something like that?
Can I alter it a bit?
Please.
If they said rocephodron, and I'm like, never heard of that before, I'd probably just check my protocols real fast.
Sure.
And I'm assuming, that would be something that I would need an IV for. So I'm like, hey, just go and grab a line for me. And that can buy me time while I look through my protocol
Sure.
and see what's appropriate.
What he's expressing is the reaction I want. Because people usually respond one of two ways. They will, and this goes for testing, this goes for the field, this goes for everything, kissing pretty girls, like whatever the case is. Like they'll encounter something and say, that was scary, hope I never see that again. Or, that was scary, when I see that again, I need to be ready. And that will be the major difference between your success in this class. Is like everything, it will be in direct proportion with your honesty to yourself. If you encounter something, if I say something, and we have to get out of our heads this should and shouldn't know these things. I should know that. I just won't. I should know that. All right. Okay, well maybe you should. So learn it tonight, right? If I say things like we're going to talk about nitro paste, it builds on the assumption that you know fully what nitro is in the first place. If you're like, vasodilator, how is it that it can vasodilate yet and lower preload, but also be good for the heart? Isn't a reduction of preload a problem? If that's a question in your mind that we haven't answered, you should ask me or dig into yourself or whatever. Again, I'm just trying to reiterate in many different ways. If you don't know, it's just like an EMT class. If you don't understand something, it might be a me issue. It might be that I didn't explain it in a way that was simple enough for you to understand. I'm okay with that. I'll do it again. So again, I think that your success here in AEMT class, and part of the reason why people fail is number one, they don't know what to teach, right? And number two, they don't know how to assess that. And then number three, the students aren't saying, oof, I don't know this, I better dig into it. And you really should, okay? What separates an AEMT, right? So we're talking about now, we're moving from EMTs, we're now in AEMT. What is the difference, right? Like, you're at a Thanksgiving dinner and they say, oh, you're an EMT, right? And we say, well, I am, but I'm in in advanced class and they say, oh, what's the difference?
In my mind, it's more invasive. We're doing more invasive things.
That's fair. Yeah, I don't think I would have come up with that, but I think that's fair. There are substantially more invasive things. What does it mean, something invasive? What are we talking about?
Like so we're putting in lines, we're doing, doing IVs, so I'm actually
Getting in bodies?
Piercing
Yeah.
skin.
drawing blood.
Yeah, for
Yeah.
sure. I might have mentioned before, but I remember when I was doing clinicals, I think it was an EMT, and guy had gotten in a motorcycle wreck, he's laying in the trauma bay, this in Flint, and guy comes in a white coat, he's like, hey guys, he's like, hey John, I'm like, hey man, puts on a glove, jams his finger straight up the dude's butthole, pulls it out, he's like, alright, I'll see you guys on Tuesday or whatever, and then leaves, and I was like, hello. So I asked my instructor, I was like, what on earth? He's like, oh, that was an anesthesiologist, he makes 6 figures. I'm like, okay, right? And that was one of the most invasive things I had seen, right? I don't know that I want that job, but of course he was checking for tonality, and spinal innervation and stuff. We learn about that kind of stuff later, but you're right. Well, moving into AEMT, we are now getting far more invasive. We're getting far more aggressive on different things as well. Anybody else? So invasive procedures, things like IVs, IOs, and the like. What separates an AEMT?
More medications that we can administer.
More medications. What do we have, including oxygen? 8 or so in EMT. Now we have about 16, give or take, as long as you count epi twice. More medications for sure. Any idea how many medications the paramedics have?
Isn't it like 48 or something? That's
I don't even
I would
know,
say
to be honest.
It's a lot. It's a
I
good
don't know
chunk.
a lot.
It's a good chunk. I always say that protocols are for EMTs, not medics. It's not entirely true, but what I mean by that is it is easier to tell you what a paramedic cannot do than it is to tell you what they can do. Because a paramedic essentially can give every med that a doctor approves. It's true for us as well, but what I mean is protocols are very, very, very important for us, and scope of practice is very, very important for us because we exist in, hey, you've only gone to school for this amount of time, therefore we're only going to give you access to this amount of stuff. Whereas paramedicine is, hey, go to school for a whole bunch of time, then you can just do whatever we tell you to do, right? And that's the trade-off in a certain sense. However, even before I was an instructor, I tutored EMTs, AEMTs, and medics for years. People that were unsuccessful in their registry and came back. And far and away, the most amount of tutoring I did was for the AEMTs, right? And the number one sentiment that they all said, do you have any idea, any guesses as far as what they would say when I say, hey, why did you fail? Why were you unsuccessful? What was it that you didn't know that having taken it several times, now you need to know? What up? I would appreciate it if you would let me know that you were going to be late.
I did, like a month in advance, but thank you. Just on signing.
Yeah, that'd be good. And then you can work with Trinity. I told Trinity she should be alone today, and she's working with you, which is basically the same. So, anyways, thanks for coming in, India.
That's on tape.
Oh no! Ha! Okay, whatever. That's how we play. Okay. Anyways, the number one thing that I had drawn from that is that a very common sentiment is they would say, here's what I would do. I'd say, hey, I'm going to lay down all these blank pieces of paper. These are drug cards. There's nothing on them. Fill these out with every one of the drugs that you have access to and all of the information that you know about them. I'll be down in my basement playing Call of Duty. And then I come back up like 30 minutes later, and there was almost always just blank sheets of paper. And I would say, you have access to just shy of 20 medications. What are you doing? They said, well, I just never really studied pharmacology because I'm not a paramedic. I'm like, oh, I know why you failed now. Because let's take one that might be a bit of a softball, right? Like, what is albuterol? Bronchodilator. Okay, instantly you use a fancy science word to pick dudes up at the bar, right? Bronchodilator, right? What does that mean? Why did you use that word? Great.
Makes you breathe gooder.
Makes you breathe gooder. I'll take that. We're getting closer. India. Albuterol in a way that I would understand it if I didn't know science.
Opens lungs.
Opens lungs is good. We're on the same. Okay. Don't you roll your eyes just like her better? I don't know what I'm saying. Okay. The point here is that you have a fundamental understanding of the physiology, the pathophysiology, and you can't all but instantly start using these terms to define what the med is in the first place. the point I'm getting at is that if you know these meds, then you must know the pathology that they're used for, which means you have to understand the physiology that turns it. So we start in pharmacology. It's the foundation of the rest of what we're doing. If you didn't know albuterol, then you probably have a very weak understanding of the airway and what could go wrong with it. If you didn't know epi, you probably have a weak understanding of histamine release or reaction, vasoconstriction, vasodilation, nitrates. I mean, so anyways, the point is that's in large part why we start here in pharmacology in A. It's one of the biggest distinguishing factors between an EMT. It's really when we start to get into the meat of things, and you can't fully understand these meds unless you have a decent understanding of the physiology and pathophysiology of it. So that's where we would start. Also, you should know that we are releasing a bit of the freedom as we move from EMT into AEMT. Before it's like, I'm just EMT, sorry, or whatever. And now it's like, no, that med's in your scope. I don't care if the medic gave it. You should have known better. It's in yours, right? Now that existed in EMT, and just saying it's far more now, right? Now they throw you a line and say, hey, why don't you go ahead and run some epi on this guy? I'm gonna need an 18 gauge in the left AC or whatever the case is, and you're just like, that's all you now. That's all your job now. Right? And so if it's done wrong, they get phlebitis, you don't ask for allergies, you give the wrong meds, their blood pressure bottoms out, it just won't work very well to say, well, the medic told me so, and they're gonna say, that's in your job. You need to know, right? So there's a bigger responsibility there, or at least bigger for sure. Anyways, so that's where we're gonna start, partly because it's awesome, because meds make you feel like an AMT for sure, but also because it's the foundation of all the stuff we're doing. So I wanna take a second, now this document, is the word I'm trying to say, is available to everybody. This is the NHTSA, National Highway Traffic Safety Administration. This is their document that literally outlines on a national level, here's what you can do for EMR all the way up through paramedic, okay? And it is expected that you know that. You're in luck in the sense that your protocols will be lined out for you as a responsibility of the medical director and the organization you work for. And there's an interesting cross-section of where responsibility lies and what you can and can't do. At the end of the day, the number one governing factor is your protocols. If you work for John Smith Ambulance, whatever their medical director said you can and can't do is what you can and can't do, because you are working as an extension of the doctor. What we don't want to say here, one of the prime examples is we teach Zofran or Ondansetron here, okay? It is not an AEMT medication in Georgia. So you learn it in class on a national level and then cannot do it in clinicals. You could if you were in Maryland or Michigan or Kansas, but we fall under the governance of the state protocols in that regard. So we'll learn it here, we'll play with it and stuff like that. There's some stuff you can't do there. There's also some other weird stuff, like we'll learn how to apply and interpret end title for capnography, but you can't do that in Georgia. You can apply it but not interpret it. The point is when you get a job and you start getting paid, it'll be up to you to read those protocols, and it will fall on deaf ears if you say, actually though, turtle's in my national scope, and they'll be like, great, you work for me though. So no, it's not, you know? So keep that in mind. It always happens, especially when people start getting jobs, when they're like, wait, all these meds and all these doses are different than you taught. And I'm like, I have a different medical director here. It's different. So we fall under that guideline. Basically what we're doing in this class is the scope is, let's say, right here. And so my goal is just to teach you everything I can on national scope. There are plenty of different things that different states let you do beyond that. And there are some things that Georgia doesn't let you do, but I'm ultimately teaching you to this line. So we'll go through it.
Do we have a copy of our protocols here at Chester?
We don't have protocols. What I tell them, our medical director sets these things. I don't know that he does.
Well, like I've had multiple chats actually be like, oh, my dose for nitro is like 0.5 to 0.8. I'm like, where did you get that? They're like, Chester.
So I give my EMTs and AEMTs drug cards. That's what they're talking
That's
about.
what you I see.
And the medics have theirs. There are some meds I try really hard to not die on a hill where I'm like, should be 0.4, and then it's like, I use 0.5. I'm like, okay, I'll just teach 0.5 then, so that they transition easier. But even them, as they move into if they move into med class, the dentist will be like, where did you learn 0.25? I'm like, Mr. Fiorani, he's like, no, it's 0.1 to 0.5. And I'm like, so that's where they're getting protocols from.
Got it.
my assumption is that there's a conversation between Mr. Denner and our medical director where he just approves whatever he serves. I don't know that. All right. Somebody tell me the difference between scope of practice and standard of care that's not listed in this paragraph. What's the difference? Or if it's easier, what is scope of practice?
What you can do.
What you're allowed to do? Okay, then what's standard of care?
What you should do.
I like that, sure. Or maybe how you're doing it, right? Now again, this is the national scope and this is how they kind of go through it and define it. They talk first, the purpose of scope deals with the question, are you allowed to do it? Standard of care is more, did you do the right thing and then did you do it properly? So it might be an example of like, well, I thought anaphylaxis, so I gave epi. And you're like, oh, okay, great, that is in your scope. But you gave it rectally? That's not how you should do that. You did the right med, you did it for the right reason, you did it the wrong way, right? And so that's essentially where that falls into play. And there's further examples here if you're at all confused about it. And I will say this, AEMT, I don't think pushes too hard on like white papers and Ryan-White Act and all these different things, but they will ask questions that base around the fundamentals, or I will ask questions around, did you know if it was in your scope? Even if it was in your scope, did you operate with the proper standard of care? And this will be one of those things I'm like, I don't know if you looked at the calendar, we do not have a med legal section in AEMT. It is assuming that you got it, right? If you're like, oh, still a little confused there. Every time you ask a standard of care question, I get it wrong on the quiz. I'm like, okay, you should call a friend or talk to me and we should iron those things out. Does anybody remember, we have here, scope of practice is often a criminal offense. You did something way outside of your scope. You intubated as a EMT, that's outside of your scope, that's a criminal. Do you already know where I'm going?
It's malfeasance and misfeasance.
Malfeasance, it can be. You're close to where I was going. Whereas this one is civil, less criminal, right? So if we have a criminal act, we call that a crime. If we have a civil act, we call it a tort, right? That's a dead ringer kind of question for sure. A civime, is that what we call it?
That sounds
Okay.
a lot more fun.
So I want to take a minute just going through the scope and looking at some of the changes, essentially, as we've started to appreciate girls and got hair in funny places and growing up so fast. Okay. We start here talking about our airway and ventilation. I have marked in yellow basically all the things that we could do as EMTs that we also can do as AEMTs. Of course, anything you could do as an EMT, you can do as an AEMT, but the stuff in blue is new for us. What is a supraglottic airway? iGel is one of them. There are about 4, 5, 6. There's Cobra, combi tubes. What's interesting is, you remember how we housed your practical registry? We do not house the AEMT, which means you go off-site. We all go together, ideally. You go off-site and people we don't know test you. What I don't know is whether or not they'll have an iGel out, a combi tube, a King, a Cobra, LMA, like, I don't know what they'll have, so we're gonna learn them all. I don't know where you're going, if you work in Maine or Michigan or whatever the case is, I don't know what they'll have there, so we're gonna do a lot of time on the iGel because it's my favorite, it's most successful, but we're also gonna introduce you to a lot of these things. Supraglottic, above the glottis, right? Supraglottic airways, does anybody know how a supraglottic airway differs from, say, an intubation? That's right, where an intubation, a medic would push a tube through your vocal cords to go directly into your airway. Supraglottics are kind of what we might call, I forget the term, but they're designed to fail, essentially, in a certain extent. Like, if I just tilt your head back and jam a tube down there, it is like 99 out of 100 times going into your esophagus. That's not where I want to push air. But a lot of these devices, these supraglottic or sometimes extraglottic, depending on where they sit exactly, they're literally designed to be okay with going into your esophagus because then they fill with air down there. And when you push air, it goes down to that part of your esophagus, up, and then back into your trachea. So they either sit covering that or sit down inside of that with dual lumens and we'll get into all of that. But the point is now, before you would say, oh, my patient is apneic, I'm going to do a jaw thrust or head tilt chin lift, I'm going to put in an opiate and bag. your next step would be, after getting their pulse ox up to a certain point, is putting in an extraglottic airway to really secure that, okay? We'll get into that later. BVMing, as you know, CPAP as well. We'll be doing more with CPAP now because we have medications to treat pulmonary edema. We need concepts of left and right-sided heart failure. Before we were just kind of like, gurgle, gurgle, uh-oh, CPAP, where it's like, what's happening? What can you do for that? Start an IV, wait, but they have fluid in their lungs. Why is more fluid the answer? Like, we're gonna know that. Chest decompression needle. It is not in your national scope, and therefore we're not teaching it. But I found no less than 4 states where it's in the AEMT's protocol to do needle decompressions, meaning pushing a needle through their chest into their lungs when they have a pneumothorax. We're not going to teach that there. It's not part of your national scope. What that means to us is we are very, very unlikely to get a registry question on that. Yep.
How are states able to go over the national part of it and push for more things that you can't do nationally?
Sure. It is a longer discussion, but suffice it to say that a doctor with approval can do whatever he wants. If he says, this is ludicrous, in fact, that's largely where EMS started, was an anesthesiologist was like, I need like 50 people, I don't care, he would take criminals, people, homeless people, and he just taught them how to do EMS, because like, we just need people. You don't have to be a genius. If I just tell you how to innovate something, you can do that, right? And so we got 44 people, and then when this all started, all black men, by the way, to start this. I can't remember where it was, but anyways, really fascinating story for EMS. So, if, for example, you went to work in Ohio, I think it was, or maybe it was Kansas, you might go in there and they a lot of these, and we'll see at the bottom here, it says asterisk, this will require medical director involvement, education, and da-da-da-da. What that means is if you go to Kansas and they say, hey, well, you're an AEMT from Georgia, anytime we have people come out of state, we know they don't know needle decompression. So we're gonna put you through this 1-day, 6-hour class where you learn it, practice it, and now it's part of your scope, and that's that. Again, we won't do that. The reason why I highlight this here is to further drive home the point. You should not be thinking, I'm an EMT with a fancy hat. You should not be thinking that. You should be thinking, there are AEMTs out there needle decompressing. That's where we live, right? Furthermore, we're gonna have a whole day on end title. I think we have 2 airway days. The first one is like, let's blast through anatomy and physiology. Does anybody not remember this stuff? Let's talk about some more in-depth stuff. And then the second day is basically all day end title. What it means, what it looks like, capnography versus capnometry, and all of these different things. What's very likely to happen here is you are going to use it on almost every patient in class, and then go out into the world, find that you have one on your truck, and your supervisor's like, will you please stop using all the end title? What the hell's wrong with you? And your response will be like, but I gained so much information, there's so much value, it's so good for the patient. And they're gonna be like, those things are like $35 a piece, stop doing that. While you're here, we'll do it all the way, because we can reuse our stuff, they're plastic mannequins, right? Anyway, this is going to become your bread and butter for patient assessment. It's the hallmark for resuscitation. If I'm a paramedic and I'm working a cardiac arrest and suddenly the end title jumps up 15 points or whatever, I'm like, this guy's got a heartbeat, right? What this means is that very likely, do you know how we're very frequently in our primary even putting people on pulse oxes just because it gives us a good information? It's not on there, but it's easy. Throw it on the finger, suddenly you get heart rate, suddenly you get pulse ox, and so on and so forth. This end title will basically become that. End title is set up in 2 ways. It's either inline, meaning I've got somebody tubed or whatever, and I'm bagging them. I detach the bag, I put it in line and reconnect it. Or as we very often will be using it, even unconscious people, it just looks like a nasal cannula with a little paddle on the front, and that's how we kind of view expired CO2. We'll get into this, like I said, it's a whole day on it, but the point is that if I'm putting oxygen in, for carbon dioxide to come out, it would have to exchange. So we can monitor that carbon dioxide to determine if their lungs are working or if it's being brought there in the first place, the blood, but we'll get into all that. That's a huge point for AEMT changes. In fact, even in this document, they say that they really wanted to teach EMTs this because it's so valuable, it's so simple, and it's non-invasive. The problem is EMT classes are often taught over 6 weeks, and this is a huge topic. Head tilt, chin lift, as we know, jaw thrust, as we know. Again, there are states where intubating is an AEMT skill. If I'm putting oxygen in, for carbon dioxide to come out, it would have to exchange. So we can monitor that carbon dioxide to determine if their lungs are working or if it's being brought there in the first place, the blood, but we'll get into all that. That's a huge point for AEMT changes. In fact, even in this document, they say that they really wanted to teach EMTs this because it's so valuable, it's so simple, and it's non-invasive. The problem is EMT classes are often taught over 6 weeks, and this is a huge topic. We won't be learning that because it's not part of the national scope, as you can say, or as you can see. But again, in fact, I think it was Mr. Simmons where I'm texting him all the changes into AEMT, and he was like, so what's the difference between a paramedic and an AEMT? I'm like, 12 leads, basically. And that's the mindset you need to be in. If any part of you is like, well, I'm an EMT, so just don't go tell the medics or medic students that you're a paramedic, they'll hate that. I'm basically a medic, Mr. Freon said so. I'm like, All of these different mouth to what's it stuff, mouth to barrier, mask, mouth, nose, mouth to stoma. My heroes, right? Lifesavers. Yeah. Ask a fireman. Anyways, we go through all these different things, suctioning as you know, and now we have tracheobronchial of an intubated patient. I'm interpreting this to mean soft suction catheter in general. So for patients with stomas or tracheas, this is no longer just oral pharynx suction. This also includes getting the French, the soft one, and tracing it down in through the tube, through our eye gels perhaps, or through the intubation, or through their stoma or trach. We'll learn a different type of suctioning there, and how we measure it, and so on and so forth. CPR, hopefully you got that by now. We're gonna be doing more of it. 12 leads, technically an EMT skill, meaning an acquisition and transmission of it, meaning you can place them, you can monitor it, and then you can send it. We did very little with this in EMT. I'd rather spend my time, I don't think in EMT is gonna get much questions on the registry about it. AEMT is different. You will literally be learning rhythm interpretation of about 5 or so rhythms, meaning you'll have test questions that will say, is this VFib or AFib or something, and you'll be expected to know that. Does anybody know the difference? We'll talk about 3 leads and 12 leads, or sometimes they'll call it monitor and a 12 lead. What's the difference? In what case would I be putting someone on a monitor as an AEMT can interpret versus putting somebody on a 12 lead? What's the difference? Outside of the numerical value. So.
I guess the 12 lead probably give you more of an in-depth look at the heart rhythm.
Very good, very good. To put the finest point on it, I would say that putting somebody on a 3 lead is like using a magnifying glass to look at their heart, whereas putting somebody on a 12 lead is using a microscope, right? Now, for the medics, I always say, if you're gonna ask cardiac questions, do a cardiac investigation. There's almost no reason in my mind, if you're like, I wanna know a little bit about their heart, but not like much, just a little. I'm like, what? So, in fact, when I teach paramedics about when to apply 12 leads, I've got this long list of like, if they say difficulty breathing or weakness, or they're diabetic with an issue anywhere, if they say chest pain, if they have sudden syncope, if they actually just maybe all the damn time, just do a 12 lead all the time, right? So, the big difference here, I often will say is, you put somebody on a 3 lead because you just want to check dysrhythmias largely, you want to get a good viewpoint of that, whereas a 12 lead is really starting to look at how the heart is tilted in the chest, whether the electricity is moving in a funny way. We're looking for heart attacks and the like. But you can learn a lot. You can learn a lot from just putting somebody on a 3 lead, and will be kind of expected to interpret some of this. Not 12 leads, I won't ask you to say, hey, which coronary artery has the blockage? I'm not asking that question, but I will say, hey, if something has blocked the heart and it's now in a lethal dysrhythmia, what are those? Draw them, right? Which one of these gets shocked? Which one of these gets epi? Which one of them doesn't is a strange question, but these types of things, right? In fact, lidocaine and amiodarone are part of AEMT scope in some, so they have to differentiate, different dysrhythmias. We won't be learning those. I would be surprised if next year I teach them, as I get familiar with, epi to A's.
Mr. Jenner was like, oh, just watch and like ask questions to me. I'm like, oh boy.
It's funny, I always am met with a certain insecurity moving into the AEMT class and fear of redundancy, and saying like, well, they know some of the slides I'm literally just repeating, I'm just going into more depth, even though it's the same slide. I get a little insecure about that, but then if it said, hey, Mr. Denner is gonna teach an AEMT class, pharmacology today, do you think you'll learn anything in it? You've been a medic for 15 years, you've taught classes, and I'm like, oh, hell yeah, I'll learn stuff in there, of course I will. I'm like, so why am I insecure about repeating if even I would learn stuff? So you kind of have to put that in the backseat of your brain, and you're welcome to ask questions. You probably have good questions. So again, we go into this defibrillation, automated, semi-automated. This is referencing the AED. There are some states that allow manual defibrillation. So if you go to those states, they'll say, hey, you're an AEMT, so you know how to shock the difference using our biphasic monitor as opposed to a monophasic, right? You'd be like, no, I need that class, right? again, I mention this to say the expectations for AEMT are growing substantially, and I think that's why the success rate on the registry is so low, because we're still caught in this like, and an EMT knows that? Is that for real? Yeah, dude, they need to know a lot, right? We've talked in the past about hemorrhage control, not the least of which is direct pressure, wound packing, so on and so forth. What's a mechanical CPR device? Lucas, sure, is one of them. There are many, right? Lucas is certainly one of them. Mr. Simmons?
Will we cover how to defibrillate with like the life pack versus old?
You will, paramedics will. We won't in this class.
Well, like the AED function.
Yeah,
If you're
so-
like, hey, you use it as an AED, I couldn't.
It's my expectation that the only AEDs we'll use from now on are through the monitors.
So we will cover how to use it as a, okay.
Yeah, so like before they were like, we pressed so hard on manual blood pressures in EMT because now we won't ever use them or seldom use them because it's like just hook them up to the monitor. I failed them if they didn't know how to take manual blood pressures, so they made it thus far, right? So they'll be running calls with monitors. The only difference between the paramedics is they won't be interpreting 12 leads, even though they'll still be graded for doing them and knowing when to do them. So they'll go into their finals and it'll be like, this is a heart attack, why don't you do a 12 lead? And if their answer is, I'm not a medic, I'm like, wrong, right? I still need you to know when to do them, even if you don't read them. So yeah, so we'll be going through that. It'll be, it's one of those things that I'll probably asterisk, like where I'm just like, oh, like a month into the course, I'm like, wait, I need to start saying which monitor to use for this lab to make sure they're using Philips and
Right.
yeah, it's a strong point. All right. You'll notice here as we move into trauma, right? We've got this list here, we've got this list here. This is part of the reason why we de-emphasize trauma discussion in AEMT. Nothing has changed from EMT. Remember trauma from AEMT? It's like that. Do it again. Now we do spend 2 classes on it. We talk about head trauma and chest trauma, but that's only because it's so tightly wrapped up with medical, because we want to talk about intracranial pressures, we want to talk about pneumothorax versus tamponade type stuff, right? Because before it was kind of like, I don't know, he got a squishy chest. Maybe it's a heart problem. Now it's like, what kind? And what would you do? What med would you give? Would fluid be bad here, or would it be the reason he lives, right? So we'll get into that as well. Nebulized medications, we're starting to get into this. This is where things get a little sticky. Again, innovation is an AEMT skill in many different states. It's not national, so we're not going to do that here. Intranasal versus auto-injector. If you remember, or now drawing the distinction, EMTs could give a decent amount of meds, but it always had to be prepared for you, like a lunchbox with a little Heart You Forever sticker in it. Whereas basically EMT is like, hey, remember how we had to assist with nitro? Now we just give that stuff, right? Which is very convenient, and I always forget when I go into EMT, they're all like, wait, can't we only assist with this? I'm like, oh, that's right, that's so stupid. Yeah, I guess so, right? So there's a ton of that stuff. Like before we could do intranasal unit dose pre-measured, meaning if the doctor, or we had these auto injectors or whatever, we can attach what is it? MAD?
Mucosal atomizer device.
I was hoping it was nasal atomizer device, and then we could all say MAD. Either way, the point is now you'll be expected to get thrown a vial of medication, draw it up as appropriate, attach everything, and then give it, whereas before it had to kind of be preset, everything had to be preset, whereas now you'll be expected to do all that on your own in many cases. One of the things I want to mention too, I guess I forgot to touch on it, is you need to be careful out there. I mean, I have a very brazen speech, pretty cavalier about what you should and shouldn't do, but you should remember as far as legal liability, that if I used to wrongfully say, if I throw you a med, let's say I throw you Versed, and you were like, dude, this isn't my scope. I'd be like, quit being a nerd, give the Versed. We're using my brain, I need your thumb on the plunger, just do it. I said that for decades. I was wrong. Whoops. This is what needs to happen, and what I want to emphasize most strongly is that if you're documenting stuff, you should only be documenting things that fall into these categories. What you do with that medic and what you agree on is a separate thing, but writing it down will hang you. You need to be cautious of that. If I get thrown a medication, I need to ask myself, did Mr. Fearon teach me about it? That's the first one. Did he talk about it, right? If he talked about it, did I get a certification? Meaning, did I complete the class? Well, if you successfully graduated this class, you are now certified. Oh, so I can give the med? No, you cannot give the med, because you also need a state license. Now, Georgia's somewhat unique in the sense where registry is the state license, but there are other states that you would have to go get a national registry and still couldn't give the med. As a registered, certified, educated AEMT, you would still need to get an Oklahoma state license before you could give that. In addition to that, they would ask you, well, good job, you got an Oklahoma state license, you completed an Oklahoma class, you were educated in that Oklahoma class, now you can give the med. No, because you're not getting paid to do it. A medical director has to approve you to give this medication. So in the grand debate between like medics versus nurses or whatever, we do have a lot more liberty, but it's not because we're smarter or better. Essentially, it's proximity. They don't give that authority to a nurse, because a nurse can be like, hey doc, you want to go ahead and do this? And then he does. Whereas a medic is like, hey, I'm alone. I am alone. Okay. Or an AEMT in many of these medications, right? In regards. So if they get, look, mostly I'm just preaching caution here, and certainly don't document things outside of your scope. That is how you will hang yourself. But if, be within your thing, they throw you a med and you say, hey, I'm sorry, dude, this isn't mine. I want to help. Give me anything inside of my scope, but I can't do this. And so even if you choose to just do that, you should know that you are legally culpable if it falls outside of your scope, okay? Keep that in mind. We talk about it in here. We talk about the 2 Colorado medics that got negligent homicide.
Was it the ketamine?
It was the ketamine. The irony of it is that it's like, even as much as we're like, it's ketamine, who cares? I'm like, you ever given double the dose of ketamine you needed to give? And you're like, well, no. Okay, well, me neither. So maybe there is something wrong there. Like, let's just play a game where we just do what we're supposed to do, then you don't get in trouble, So, we'll take a break once we get through this stuff here. COVID changed some things where they started to say, oops, maybe you can use N95s inside out for hundreds of hours and on a friend's head. Like, a lot of rules changed when COVID happened, and one of those was with EMT and immunizations, meaning they were like, hey, we're kind of in a critical mass here with needing hands, so we're gonna let AEMTs do a certain amount of things, whereas AEMTs just always can give immunizations. So you could go work in a clinic that just gives out COVID vaccines as an AEMT, for example. But you couldn't as an EMT unless it was declared a public health emergency. So there's some differences there. We talk about inhaled, monitor patient administered in regards to opioids. This is a weird thing. You will never, ever, 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 asterisk, comma, hyphen, ever, use nitrous oxide on an ambulance. It is, however, inside of your scope. Does anybody have any idea where you might use nitrous oxide, or where it is used? Dentist. So you could, presumably, get a job as administering nitrous as an AEMT because it's in your scope. In fact, where you're going to struggle is I'm going to have test questions that say, your person is in pain, what should you do? And you're like, nitrous, that's so weird. That is the answer. If nitrous is the answer, is on there, and it's an opioid analgesic or opioid adjacent analgesic, you need to answer that. You need to get in your head that you do have pain management. Nitrous is one of those. So what that will look like in lab is I want to hear you say things. Guys like, I don't know, dude, my left flank just hurts so bad. And you say something to the effect of, okay, well, I would consider nitrous. I don't have access to that, so I'm gonna I'm not saying I'm gonna grade you on it, but I wanna hear it, because I want you to think about it when you're doing the written test, that nitrous is in your scope even if never available, okay? Now, incidentally, it might be even harder for this class because we got a ton of different pain meds like Toradol and acetaminophen and arguably aspirin. So you might be asking yourself a series of questions about which pain med to give. But I don't want you to forget nitrous is the point.
Why is that something that they put in the scope that don't put on drugs?
It's the same reason why Hawaii Walmarts have to say, please don't send us snowblowers. Because you are in a national class that crosses not just ambulances, but fire, institutions. It is entirely possible that there are AEMTs working in places where their whole job is to give immunizations, even though we don't do it in EMS ever. Or that something like a nurse, what do you call it, dental hygienist? What's the assistant?
Dental assistant.
maybe they need some type of caveat or licensure, and it's just easier if you're an AEMT and can do that job and give nitrous as well, or something. So the point is because much like Walmart is all across all these states with varying elevations and temperatures, so too does the AEMT licensure cover a myriad of different jobs. You can work on oil rigs or in hospitals or at fairs, and it's just somebody somewhere was like, dude, I'm an AEMT, why the hell can't I do this here? And the answer wasn't, well, because you're not an ambulance. Like, well, this is well within my education. Nitrous. We're gonna be doing IVs, it's a big point, right? It's a big point of what we do here. We spend several days and many, many scenarios. Let's make Dennerts really break the wallet here. You know, I really want you I want your expectation to be that even if you show up to a big plastic mannequin to say, I'm gonna start an IV, to ask that adjunct, where's the separate arm? Where's the arm at that I can start a line on? For you to opening packages, throwing away needles and stuff like that. We probably won't throw away flushes because those are easy replicated, but I want you to go through the experience of live pointy needle sticks over and over, and for me to have to say, hey, we need more. These kids are burning through them. We do IVs all the time. That's my expectation. And so if you get an adjunct that says something like, you don't have to open that. I would rather you say, well, can I? I'd rather go through the experience. That's what I want. I want you to end this with thousands of IVs. See what I'm saying? That's my expectation. Also, several of our meds go through in that regard. Now, they are non-specific in this. One of the IV meds they mention is limited to analgesia. What does that mean?
Pain relief.
Pain relief, sure.
Or
What
my
is-
coworker accidentally says anal Jesus.
Yeah,
Yeah.
sure. That'd be an interesting sermon.
Don't tell the answer.
I imagine at a certain point it's not accidental, but what is an example of an IV medication that's an analgesic? You're lucky you're in A class. Don't worry, I'll teach you.
Acetaminophen.
Acetaminophen is one of them, sure. The point I'm going to make is that there are many. Is fentanyl an IV medication analgesic? So, should I teach you fentanyl? I don't think so. It doesn't say that. So I'm not teaching you that. And the point I'm making is you need to be careful not to think that what you're learning here is the end of your education. You shouldn't think, well, he taught me acetaminophen and ketorolac. What are you talking about? Lidocaine as a topical anesthetic or whatever. This should be the beginning of your education, not the end. Okay? In addition to that, we're only going to be talking largely about Zofran, but there are plenty of IV medications that work similarly. Some that work better than Zofran, in fact. We'll be talking about IV dextrose, IV epinephrine. I will not be teaching you IV glucagon. Does anybody know why? Do you know why? They probably won't. Do you have any idea why I'm not teaching IV glucagon?
Specifically, I mean,
Mm-hmm.
Caustic.
That is it is possible, meaning it is permissible, but that's a good guess. Let me ask. Say again.
I just know it's IM, but I'm not quite sure.
I bet we can get there. I call out to you, walk in the door as a second unit. I'm like, oh, hey, I'm glad you're here. I need some glucagon. Why am I asking for that?
You couldn't get a line.
Because I couldn't get a line. If you can get a line, what are you going to give through it?
Dextrose.
Dextrose.
Oh.
So why the hell would I give IV glucagon if I have a line? Because basically you'll see on the indications for glucagon is, if your patient is hypoglycemic and you can't give dextrose, only then give glucagon. So that's why I'm not going to teach you IV. And we'll get into exactly why later, but that's that. We'll talk about naloxone as well. What does this mean? Parenteral analgesia for pain. Parenteral.
Isn't that going through the digestive system, going through the gut? No?
You are close, but
Isn't that-
completely wrong.
Oh, alright, that's fair.
Isn't that where it like goes through your heart, maybe?
Uh,
Something where it like
I
goes
don't
into
know.
your like your bloodstream?
Here's the way I look at it. Enteral is stuff you eat.
Because it's what
Because it starts with
letter?
E.
Because it rhymes
So
with-
parenteral is all the stuff you ain't eating. Meaning an IV medication would be parenteral.
Okay.
So the opposite of goes through your gut.
Yeah,
Yeah.
that's exactly. That's why I'm like, you are so close, but it's actually like
Somehow it gets to the
as
blood.
close as the opposite side of a coin could be, I suppose. There are some complications there, like I have to look up before I teach you, like buccal, is that technically, because it is gastric, it does do pass by the liver, but it's in, I don't remember, but mostly it's eating versus not eating. Sublingual nitro, here's a big change here. Before, we had to assist with it. Now we just administer it, meaning it will be in our bags. But we're also gonna do nitro paste. Have you ever heard of this, or do we know what the purpose of nitro paste is? Okay. It's a transdermal medication, we'll get into that, but we're now gonna be giving nitro. The summary of why I'm teaching you nitro is because we're now going to be giving nitro for pulmonary edema. Anybody have any idea why we would give nitro for pulmonary edema?
Reduces bleeding.
Oh, impress me here, Tony. I'll
Since
graduate you
nitro-
right now.
If nitro is a vasodilator, then would it open up the blood vessels to help slow down blood flow?
That, to help slow down blood flow?
Yeah.
That is correct. Why is that beneficial for a person with congestive heart failure?
Make them last longer. You know, really try to get them to the hospital faster.
Okay, you're close, but ultimately, it's weird, right? Because if I'm in heart failure, you might think, hey, we should return like blood and oxygen to the heart so that way it can fail less. The problem is that's much like if you're pushing down on my wrist or whatever. You know, I'm like, oh, I'm losing strength, and you're like, well, then push harder on it. Give it more. It's gonna cause it to fail more, right? What we want is to actually cause less blood to go to it, so it doesn't have to push as hard. It's a little counterintuitive, right? In fact, we often think, well, we're putting CPAP on because we're just trying to press the water out of the lungs. Not really. We're trying to increase thoracic pressure so less fluid comes in. We're trying to decrease preload. Close though. You are correct, completely correct, essentially, up until just not being able to sink it. That was a basketball thing, right? I know it looked like I was pouncing on a deer, but I've shot a basketball before, trust me. All right. Oh, so here's part of the point then. We're getting a little ahead of ourselves, but so then why nitro paste? What do you do for a person that is having pulmonary edema? What do you want to do? How do you want to help them?
Reduce the preload.
You want to reduce preload? I'll take that. How do you do that?
Nitro.
Nitro, excellent. Okay, what else? Guys, all of a sudden I can't breathe. You listen to my lung sounds, pulmonary edema. You're like, boom, let's get this fellow some nitro. Great, that's an AEMT thing, and I love it. Is that all? We going to the hospital now? CPAP. Why?
To keep lungs covered.
Increase thoracic pressure, right? Man, whoever told you that's a genius. Probably very handsome. Yeah.
What about hypertrophy bromide?
We'll get into it. It's a longer discussion, but I am okay with that. Okay, well, it's a longer discussion. The shortest answer to that question is that's a great thing to do last. Okay, it'll be on a longer list of things to do. Or if you're writing last, write later. It's a great thing to do. It should not be first line treatment, is the point I'm making. Anyways, okay, so let's say you do that, right? You give me a nitro, great, put me on CPAP, 3 to 5 minutes later, you're like, hey, let's give them another nitro.
You can't take CPAP off.
Well, you can, but you shouldn't. Why shouldn't you?
Because all the fluid rushes back.
Sure, right? If I'm pushing, Ray's pushing against me, and I take CPAP off, Ray pushes all the way through, so we might have refractory fluid to come in. So now, we do transdermal nitro. So we don't have to pull it off every time. And one of the things that will separate my students from, say, the field is we'll be clever enough to just give a good spray or tablet before we put CPAP on. A lot of people are just like, boom, CPAP, and now do transdermal nitro. And transdermal nitro is, I almost didn't teach it to you based on how useless it is. So I'm like, hey, give them a quick spray, quick tab, then put the CPAP on, then do the transdermal, because a lot of people throw CPAP on, then do transdermal nitro and don't see a lot of resolve there. So. All right.
Why?
Why doesn't it work? If I gave you a heroin patch or a heroin needle, which one do you think would work faster? Needle. Why?
Because it's injected in.
Right into the bloodstream, right? So there's the answer to your question. Because transdermal absorption is slower and bioavailability is less than, say, giving it directly into the bloodstream, or if this is how fast IV goes, and this is transdermal, then sublingual would be. It's actually relatively fast, actually, believe it or not. It's actually much closer than that, but it's faster and better absorbed. We're gonna be doing IOs. What's an IO? Interosseous. What's that mean?
In the bone.
In the bone. It's gonna be awesome. So this one is green. we'll get into this later. Does anybody know what a bolus is? What the word bolus means?
When you're giving fluids really quickly, a lot.
I'm okay with that. You should know that over 10 minutes is still a bolus. So like me slamming a syringe is bolus medication, but so by most definitions is running it over 10 minutes. Because it's not a drip, even though it is dripping, right? So if, for example, if I say, hey, I want you to put that med in this bag, attach this, and then run it over 10 minutes, that is still technically a bolus by most metrics. The only reason I say that is I don't think that's coming as a test question or anything, but I don't want you to think that, oh, I'm now running an infusion. Because I set up a bag and I'm running a drip and I'm counting the time. It's not an infusion. We don't do infusions, in fact, as an EMT, or an AEMT rather. Infusions are like, I put it in over 10 minutes or something. I run in dopamine by mixing up the bag. We're in fact not even really supposed to transport as an AEMT, unless your medical director says so, medical infusions. So as an AEMT, you're not taking pumps with labetalol and da-da-da-da-da-da, right? Anyway. So don't mistake the fact that just because it's running a bag and just because it is dripping, you're not running an infusion, you're not maintenance a drip, these kind of things, maintenancing a drip. Here's another thing that we don't touch much on, OB. Or delivery. We will do some delivery, we will talk some OB, but what before took us like 2 or 3 weeks is now gonna be in like 1 day. And it'll be like, hey, trimesters, some emergencies, nothing has changed there from EMT to AEMT, right? You need to differentiate breach, you need to know what GPA is, you need to know, if I said to you, what's a distinguishing factor? How might I know, let's do raised hands here. How might I know that or suspect that this woman has abruptial placenta? Why might I suspect that? Trinity? Tearing pain. What else causes tearing pain? AAA, very good, right? Okay. Now I think, my partner said, I think it's gonna be abruptial placenta, and I say, I don't think it is. She's not talking about a sharp pain. In fact, she has no pain at all, but she does have some bleeding here. Got you. You're in the nose crew. Destiny?
Placenta preview.
Placenta preview. Okay, so if you're like, that wasn't obvious to me, then it'll need to be. And that's work you largely have to do on your own. Like I said, we're gonna fit like 3 weeks into 1 day where I'm like, boom, placenta preview, boom, abruption placenta. And it's on you to say, okay, wait, I need to make flashcards for these. I still don't got them. Okay, right? So we're gonna move fast through that stuff. We are gonna be doing some neonatal care because we can give dextrose and Narcan and cardiac epi to neonates, and those doses change based on those ages. It's a bit tragic, but we hold you to a higher standard, essentially. Most everywhere you go is gonna say adult dosing, no math. Pediatric dosing, some math. And pediatrics include newborns, not here. We go to the NRP, the National blah blah newborns, I forget what their acronym is or stands for, but they are like the AHA of newborns, right? That's where we get our algorithms, that's where we get the golden 60 seconds, that's where we get all of that stuff that we taught you, and they have different neonatal doses, like dextrose is lower and epi is higher than pediatrics, so we learn kind of to a higher bar here, which is why we're going to focus a bit on med admins for neonates. Do you ever think you'd be in a world where you'd be teaching AEMTs how to give a 32-year-old cardiac epi?
No.
Here we are. Another thing that we're going to do is venous blood sampling. Really, there's not a lot to say here. After you know how to do an IV, it's just a matter of taking those little green, blue, red, rainbow tubes or whatever, sticking them in there, watching them fill with blood, and being done with it. What's interesting, no, is it this? No, it's not this one. We don't have that stuff in yet. We've ordered it, so we're probably going to do that later, but it shouldn't be a big deal. In fact, I really kind of have to learn this first before I teach it to you. I've never done that outside of my clinicals, and it was simple as I said. Put a vacutainer on. What do they need? 2 greens, 1 blue? Got it. Done. What happens there is that a lot of EMS does have protocol. I knew a guy from Las Vegas that came over to Michigan, and he was like, hey, where are your tubes for blood sampling? Because what they would do is like, she says she's got a headache, I start a line, I draw up 3 labs because I figured they're gonna wanna know what's in her blood, they're gonna wanna check this, they're gonna wanna check that. So I draw those 3 things, I say, hey, this is Peyton, she's 86 years old and she's complaining of a headache, here are her labs. And most nurses are gonna say, oh, thank you so much, garbage. Why would I use yours, I'll just draw mine and all this different stuff. So it's not very common in EMS, but it is part of your national scope as an AEMT, so we will be doing that. What that probably means is that your scenarios will turn into, I'm gonna go ahead and start a line, primary, blah, 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 secondary, I'm now checking for all these different things. I'm gonna go ahead and get another set of vitals and draw blood samples before going over to the hospital, and it'll be like a singular point, right? So it'll be a common thing for us, yeah.
So is it in our Georgia scope in the way that like we're on clinical ERs that hey, we need blood drawn?
Nope. And that one will be easier because no one will have them. Even the medics don't do this. So it like, whereas Zofran, you might just be like pulling up Zofran and pushing it, and the medic won't know, you know. Mr. King will be like, oh, don't do that. You know, the blood thing, you'll be like, all right, let's go ahead and draw samples here. They'll be like, we don't have those. So, you know, you won't fall on victim to that. All right, and that is primarily that. I got 10:23, let's call it 7 minutes.